A very good evening to all distinguished colleagues. I'm Dr. Sameer Muchala, heading the Medical Affairs at Zydus Healthcare Limited. It gives us immense pleasure today to invite each one of you to this live webinar on a new agent to the armamentarium for high LDLC management. We all know high LDLC is the single most risk factor for cardiovascular disease. Statins form the cornerstone for dyslipidemia management. However, as per the recent established data, as per the recent stringent LDL targets, many of the patients have uncontrolled LDLC despite using maximally tolerated dose of statins. Or many of the patients do not achieve their LDL goals because of their inability to take statins because of statin intolerance. Again, a factor which is quite prevalent in this part of the country. So after a long wait of about 20 years in the oral category, we have a new age management of uncontrolled LDLC post use of statin or in statin intolerant patients, and that's bempedoic acid. So to enlighten us more today, we have with us Dr. Krishnakumar, who actually needs no introduction, but it is my moral responsibility to introduce Dr. Krishnakumar. Dr. Krishnakumar is Professor of Cardiology and Senior Interventional Cardiologist at Government Medical College Trivandrum. His interests include complex coronary interventions, peripheral vascular interventions, and fistula interventions. His research interests include familial hypercholesterolemia. Recently, he's published a research article on target exomes sequencing in South Indian patients, where he has found 9 new genetic mutations reported for the first time from India. Also, one of the mutation is reported for the first time in the world, and this mutation was included in the genetic database of NCBI of USA. So a warm welcome to Dr. Krishnakumar. May I request him to take the academic proceedings forward.
Thank you, Sameer. So good evening to all. First of all, I would like to welcome all of you, all the viewers to the online platform. Now, this session is on a new molecule called bempedoic acid. That is a non-statin management of the dyslipidemia. So I'm just sharing the screen right now. So bempedoic, the title of the talk, today's talk is Bempedoic Acid in Uncontrolled LDLc, Unlocking Concept and Unleashing Efficacy. Before getting on to the presentation as such, I would like to mention 2 or 3 facts. Because now, these days, it is an exciting, for the last 2 to 3 years, an exciting time for cardiovascular prevention, especially CV prevention, because there are a lot of non-statin drugs, especially in the management of LDLC or dyslipidemia, is out there in the world, especially PCSK9 inhibitors like evolocumab and alirocumab. And now that is not available in India. There's another PCSK9 small RNA inhibitor, PCSK9 production inhibitor, inclisiran is coming. And nowadays, right now, I think this molecule, the new molecule, bempedoic acid, has been there 2 years before launched in India in 2020, the US and February US, and 2020 March in Europe. So that the addition of bempedoic acid to the existing armamentarium like statins, the first choice is statin. Second one is ezetimibe. On top of that, if you are adding another non-statin drug for the uncontrolled LDLC, so that will be a very, very good addition, especially that may beat PCSK9 inhibitor, because this combo has been titled as or termed as a poor man's PCSK9 combination. So it will achieve around 65 to 70% of LDL reduction. So right on to the next slide, you can see that any dyslipidemia or any atherosclerosis, the concept of atherosclerosis in the mid-19th century, it was initially between 2 great German scientists, that is one Rudolf Virchow and von Rokitansky. They have said it is, one of them said it is because of the incorporated thrombus in the arterial wall. The other said it is due to the inflammatory reaction. Later on, in the 1900s to 1970s, it was another theory has propped up, that is lipid storage disease. It is due to the atherosclerosis is due to the lipid accumulation in the arterial wall, intima media interface. Then in 70s and 80s, it is a smooth muscle proliferation that causes atherosclerosis. And in the 1980s, it was innate and adaptive immune response. So the current concept is synthesis of all of these. But the major thing is lipid storage disease and associated thrombus inflammatory reaction. So you can see that because nowadays people are having a different thought. Is it lipid lowering is enough, or is it the anti-inflammatory therapy, especially canakinumab and all, that is important. So that is Peter Libby and Strandberg et al. Have done a beautiful editorial, A Tale of Two Therapies, lipid lowering versus anti-inflammatory therapy, a false dichotomy. What they are trying to say is inflammation does not supplant or demote traditional risk factors such as LDL, but provides mechanisms that link them to altered arterial wall function. That means even in this era of latest day of anti-inflammation and all, it is the LDL that remains the sole agent that is responsible for atherosclerosis. So from the biology of atherosclerosis, the current dyslipidemic burden, why I have taken this slide is that this is recently presented in the European Atherosclerosis Society, and so they have shown the Northern California Kaiser permanently cohort, South Asian people. South Asian means predominantly Indian population. You can see the orange bar male population. They are having the highest of coronary artery disease incidence compared to Hispanic, whites, multi-ethnic, blacks, and Asian, apart from other East Asians. So our population, Indian population, is having a significant burden of coronary artery disease. And this is also due to major driver of coronary artery disease, according to the Interheart studies, lipids. It has got a population attribute, PAR, that is population attributable risk of 90%. And so from the pathobiology of atherosclerosis to the dyslipidemic burden or the coronary artery burden among the Indians, now we are coming on to the what are the existing therapies that are available to treat dyslipidemia. You can see in this slide, you can see that 1 millimole, if you are using statins, it's a meta-analysis of statin, major coronary statin 14 trials. You can see that 1 millimole, that is 39 milligram per deciliter reduction in LDLc, was associated over 5 years with 23% reduction in major coronary events and 21% reduction in major vascular events. So there's a significant reduction of vascular and coronary events. Apart from coronary events, there is vascular event also decreased with the usage of statins. But even with the good high intensity statin therapy, see, you can see incidence of major cardiovascular disease events in levels of LDLc in levels in patients receiving moderate or high intensity statin therapy. You can see the blue thing is moderate intensity and light blue is high intensity. So even in the high intensity population, there is significant amount of residual risk is remaining. So this slide denotes the fact that even though there's a good statin treatment is available, especially with the high intensity statin, but there's a significant amount of residual cardiovascular burden, residual risk of atherosclerotic burden or lipid burden in the coronaries or the vascular trees, even with the current best of the treatment that is statin. So you need some more treatments apart from statins. So what are the guidelines says? So every year, I think from the 1998 ATP1 to 2019 European guidelines, the bar of LDL goal is lowered. So you can see that according to the 2019 European guidelines, European Society of Cardiology guidelines, you can see on the left-hand side, the LDLc target that is 40 milligram per deciliter. You can see if the patient has got a repeat ACS, that is acute coronary syndrome, it means if the patient, the ASCVD, that is atherosclerotic cardiovascular disease patient, has got a second event within 2 years, the goal of the LDLc is down to 40 milligram per deciliter. So in very high risk patients, according to the US guidelines, it was 55 to 70. But in repeat ACS, according to the 2019 guidelines, it is 40. This is according to as per the European as well as the US guidelines. But our own Lipid Association of India goes further down. You can see this is the algorithm for treatment to achieve LDL cholesterol goal in very high risk and extreme high risk group patients. That is according to the Lipid Association of India guidelines. You can see that they are showing the guideline LDLC level of less than or equal to 30 milligram per deciliter in extreme, that is polyvascular disease, diabetes with the target organ damage. In all these extreme risk group of patients, the optional goal is less than or equal to 30 milligram per deciliter. So what I want to convey from these two slides, the guideline slides, is that even though statins are available as a best treatment right now for the management of dyslipidemia, the control of lipids with statins is suboptimal. Why? Because to get a very good control to amelioration of the symptoms or the decrease in regression of the plaque, you need LDLC goal down to 30 milligram per deciliter. That is not possible with high intensity statin therapy in majority of the cases. So you need another therapy, non-statin treatment to counter this. So patients with low LDLC benefit from adding a non-statin treatment on top of statin. See, you can see this is a trial, Improve It trial. You can see this is with the statin on top, ezetimibe on top of simvastatin. And this is another non-statin treatment called PCSK9 inhibitor, Fourier trial, that is evolocumab. So this baseline LDC level, you can see that 50 to 70 or 70 to 100. Even in these subgroups, the so-called low LDLC, previously when your patient has got a 50 milligram per deciliter or 70 milligram per deciliter LDL, you will say that that is normal. But if you are adding ezetimibe on top of this, you can see severe death, major coronary event or stroke is significantly decreased. You can see the hazard ratio. You can see that overall percentage is on the left side of the unity line. So that is ezetimibe with statin combination is better in this so-called low LDLC. So you can see the trials with Fourier, that is evolocumab trials also. Baseline LDLC less than 70 milligram per deciliter on high intensity statin. If you are adding evolocumab, you can see that there is significant decrease in cardiovascular death, major coronary event or stroke. So even in this era, if you are the so-called LDLC is benefited significantly with the addition of non-statin therapies. So we will see the non-statin treatment available right now. First one, we will see ezetimibe. Ezetimibe is a cholesterol absorption inhibitor, works at the androcyte brush border, interacting with the receptor, Niemann Pick type C1-like receptor. It lowers LDLC by about 15 to 20% as monotherapy. Monotherapy of ezetimibe is used in cytosterolemia or statin intolerance previously. It is available as an oral 10 milligram tablet. It is additive with statins, that is further LDLC reduction up to 5 to 35%. So it decreases LDLC by 15 to 20%. On adding statins, it will go up to 35%. So Improve It showed cardiovascular outcomes benefit. So ezetimibe is having cardiovascular outcomes benefit also, and it is comparatively cheap also. But even though ezetimibe is available for a long time in our country, it is significantly underutilized. And it has got very few side effects, occasional muscle or VA symptoms. Particularly helpful with FH patients on lower intensity statin therapy. And so that is the advantage with the ezetimibe. And now we are going to the another non-statin therapy that is available right now, that is called PCSK9 inhibitor. So with evolocumab, that is available. Evolocumab is not available in India. So there was a trial called GLAGO. GLAGO was an intravascular ultrasound trial. You can see that with the addition on top of optimized high intensity statin therapy, if you're adding evolocumab, you can see the line, the midline, that yellow line. See, if the LDLC is down to 110 to 90 to 100, you can see there are still there is progression of the plaque according to the IVUS intravascular ultrasound. If the LDLC is down to 60 to 90, there is no progression of this plaque as per the IVUS criteria, that is 60 to 90. But if you are maintaining in the LDLC down to 20, that is 15 to 20, you can see there's a regression of the plaque. So this is the first time that a study shows that there is regression of the plaque. So regression of the plaque is there if the LDLC is down to less than 20 milligram, 20 to 30 milligram per deciliter, even if the treatment is PCSK9 inhibitor or other mechanisms. The mechanisms doesn't matter, the drug doesn't matter. It is the level of the LDLC that matters. So you can see that the Fourier trial, see the LDLC down to less than, the violet line shows that less than 20 milligram per deciliter at 4 weeks. So even in 20 milligram per deciliter, you can see that, there's a significant 31% relative risk reduction compared to 20 to 49, all those other. So what we are trying to say is that the lower is the better with the addition of non-statin treatment. And for the first time by using in ACS patients, by using optical coherence tomography screening, you can see that this is a 12-week follow-up study. Baseline therapy rosuvastatin 5 milligram plus or minus evolocumab. Stage PCA at week 4 with OCT at 0 for 12 weeks. You can see that initially the lipid arc is 123 and the fibrous cap is less than 58. So the thin fibrous cap is called a rupture for plaque rupture. So after giving 12 weeks of therapy with evolocumab, you can see that the fibrous cap thickness is increased because of the addition of stabilizing tissue. With the removal of plaque burden, there is fibrous cap is thickened 78 micrometers. So the existing, if you are going down, the LDLC is going down a certain limit, less than 20 or less than 30, there is regression of the plaque is there. That is also shown in ACS population also. And some of the people means previously when the LDLC is down to 50 or 30 or 40, people were alarmed. Is it safe? Because previously there was a concern that it causes hemorrhagic stroke. So the ezetimibe trial that is improved, or the Fourier trials with the evolocumab, that significantly shown that, conclusively shown that there is no significant side effects. You can see that all those violet purple bar is less than 20. There is no new onset diabetes mellitus, cancer, cataract, neurocognitive effects, no hemorrhagic stroke. So it is fairly safe. The safety events, if you are going low LDL levels, it is fairly safe. So till now, we are having statin, PCSK9 inhibitor, and ezetimibe as ezetimibe and PCSK9 inhibitor as non-statin therapy. What sort of LDLC reduction will be there? Average LDLC reduction with the moderate intensity statin, it is 30%. High intensity statin, it is 50%. And high intensity statin plus ezetimibe, it is 65%. So you can see that if your patient is on high intensity statin, you are adding ezetimibe, you will get a 65% reduction in LDLC. So if you are taking the costly PCSK9 inhibitor, that is alone, that is 60%. PCSK9 inhibitor plus high intensity statin, that is 75%. PCSK9 inhibitor plus high intensity statin plus ezetimibe, 85%. These data are till the before the advent of bempedoic acid. So the non-statin therapy that is available till that time was ezetimibe and PCSK9. You can note that high intensity statin plus ezetimibe are having a 65% LDLC reduction compared to the PCSK9 plus high intensity 75. So even with the good cheaper ezetimibe non-statin treatment, you are having a very good control of the LDLC. And even what I am saying is the LDLC non-statin treatment are available. There is this paper has been presented in the ESC Preventive Cardiology April data, current lipid lowering approach and LDL target achievement in very high risk patients in hospital results of a high volume primary percutaneous coronary intervention tertiary center. You can see that this is a center from the Italy. See, there is significant underutilization of statins. See, at admission, the median cholesterol level of a very high risk population was 84 plus or minus 31. So guidelines were not at all achieved in this. This is a high volume center that is in Europe with the best education level of the patients, best infrastructure facilities. Even then, there is a significant amount of underutilization of the current therapies are there. And patients with recurring ACS patients, ACS events where despite high dose statins, they were not prescribed ezetimibe. So a greater utilization of non-statin lipid lowering therapies is likely needed to reach the LDLC optimal target. So even though non-statin treatment are available, the physician has to shut his clinical therapeutic inertia and patient has to be motivated, and you have to give proper communication on the relevance of the usage of intensity of lipid lowering treatment. Because I have already detailed this intensity of lipid lowering treatment, I am not going to the details of the intensity of lipid lowering treatment. And the same thing is Da Vinci study that is in the current prescribing practice of the lipid lowering treatment in the Europe, you can see that 56 in very high risk population, 76% of the population is dyslipidemic population does not achieve these significant goals overall. Very high severe risk patients, 87% did not achieve to the European Society goals. So in the recently concluded European Atherosclerosis Society 2022, Professor Kaushik Ray said in 2020-21, approximately 20% of the high and very high risk patients don't receive any LLT. So there is substantial underuse of statins persist in a large insured and contemporary cohort of patients with ASCVD from the United States. In particular, concerning gaps in appropriate statin use remain among younger patients, women, and those with non-chronic ASCVD. With this slide, I want to mention that even though there are good drugs are available, we have to shed our own therapeutic inertia, and patient has to shed their own anxiety or unfounded fears regarding statin use. And the physician has to have a good communication with the patient, and physician has to go for high intensity statin. And if the LDLC is not achieved, they have to go for non-statin therapy for the good achievement of the LDLC goals. So what are the limitations of the current therapy? The current therapy I have already told, around the significant residual risk is there, and it needs additional lipid lowering drugs, and statin therapy adherence is less, and some of the around 10% of the patients risk of developing diabetes, and fibrates are not having effect on LDLC. PCSK9 inhibitors are very costly, and ezetimibe is lowers cholesterol, but it didn't slow the progression of atherosclerosis. But even then, it is significantly underutilized. And statin intolerance means whenever the patients are saying I'm having aches and pains with statin, the physician, mostly physician, they will try to stop the statins. But that is not correct, because the prevalence of statin intolerance is very, very low. Because previously it was thought that around 20 to 30% of the patients that are who are on statin, who are complaining muscle aches, maybe due to the statin intolerance. But the recent study also shows that it is around 79% or 69%. And what is statin intolerance? Statin intolerance is common. Most symptoms are not caused by the statin. Try to means you can maintain focus on achieving LDLC goals. Treat and manage underlying conditions like hypothyroidism, vitamin D deficiency, drug interactions. So in most of the cases, whenever the patient says it is muscle symptoms or muscle aches and all, it is not statin intolerance. If there is mostly due to the underlying hypothyroidism, underlying vitamin D deficiency, and drug interactions. So you have to treat and manage these things. And even microdoses. Microdoses means 5 milligram rosuvastatin every 3 days or 10 milligram of atorvastatin every 3 days. We will be having around 16 to 20% of LDLC reduction. So now we are going to the topic of the discussion, that is bempedoic acid. This is the significant advance in the management of dyslipidemia for those patients who are not optimally treated, maximally treated with high intensity statin and ezetimibe, the addition of a new drug called bempedoic acid. First, we will see the mechanism of action. You can see that bempedoic acid has got the mechanism of action is similar in the cholesterol pathway as with statins, but it is a 2 steps higher upstream. So bempedoic acid is a prodrug. It's activated in liver by very long chain acyl-CoA synthetase, and acts in the same cholesterol synthesis pathway as statins. It inhibits an enzyme called ATP citrate lyase. So because significant decrease in cholesterol is there, and because of this, LDL receptors are increased, upregulates the LDL receptors, and increased LDLC clearance and decreased plasma LDLC is there. The same mechanism of action I have shown in a different cartoon, but just to show that the bempedoic acid is competing with the uric acid for the receptor called OAT2, the organic ion transporter 2. Because of this thing, a side effect, there is increase in uric acid and mild elevation creatinine is there with the use of the bempedoic acid. That's why I have shown this slide. So what is bempedoic acid? Bempedoic acid, with the usage of bempedoic acid, there is 15% of reduction in LDL levels when added to statin, and 25% in patients not on statin. Bempedoic acid is indicated as in statin intolerant patients. So statin intolerant patients, if you are adding bempedoic acid, there will be 25% decrease in LDLC. But if you're adding on top of statin, there is 15% additional reduction in LDLC. Combination of bempedoic acid and ezetimibe lowers LDLC to the tune of 35%. So bempedoic acid plus ezetimibe combination will lower the LDLC down to 35%. It is active in the liver only, not in the muscle. So the muscle symptoms are not there with the bempedoic acid. And if you are using pravastatin or simvastatin, that is not commonly available, easily available in our country, there is dose adjustment is needed. Overall good tolerance, uric acid increase and gout is a problem in small number of cases, and rare instances of tendon rupture, primarily patients on statins. So there are significant number of trials called clear trials, that is cholesterol lowering with bempedoic acid on ACL inhibiting regime. You can see clear harmony and clear wisdom, that is on patients on maximally tolerated statin background therapy, and clear serenity and clear tranquility, that is on patients on statin intolerance or very low statin therapy. And there's a new trial that is going on. So only dose finding and safety trials are there, with the efficacy trials are over with the bempedoic acid. And there's a new cardiovascular outcome trial is on the pipeline that is getting published by 2023 last quarter. That is a clear outcomes trial. The exclusion criteria in the trials were fasting blood triglycerides greater than 500 milligram per deciliter, recent history of major cardiovascular events, transient ischemic attack or unstable or symptomatic cardiac arrhythmia, history of severe heart failure, uncontrolled hypertension, and uncontrolled diabetes were excluded from these trials. So what are the effects of bempedoic acid on LDLC in this trial after 12 weeks of treatment? You can see that in this clear harmony and clear wisdom trials, 16.5% reduction in LDLC mean percentage change from baseline to week 12 is there. And there is 15.1% reduction in the clear wisdom trial. In statin intolerant or very low statin trials, it is 23 to 24% of decrease in LDLC is there. And you can see that in addition to the LDLC, compared with statins and compared with ezetimibe, there is significant advantage in the case of significant decrease in hsCRP. You can see that in statin, maximally tolerated statin patients, around 19 to 22% decrease in hsCRP. There's a risk marker for inflammation is there. So this inflammation is also a pathway for nidus for atherosclerosis or cardiovascular base events and all. And in statin intolerant patients also, hsCRP is significantly decreased, 25 to 32%. So this is an advantage with the bempedoic acid. And you can see that a significant proportion of patients initiating bempedoic acid is achieving LDLC comparable to moderate or high intensity therapy, especially in patients receiving little or no statin therapy. What I want to convey from this slide is that, see, if the patient is statin intolerant or not tolerating statin, if you are giving bempedoic acid, around 10% of the patients is having 50% reduction of LDLC, and at least 30% of the patients is having 51% reduction in LDLC. So that's a great advantage. So enhanced LDLC lowering with bempedoic acid may also be achieved in patients with hypercholesterolemia who are often undertreated and at high risk of cardiovascular event, including women, patients unable to take a statin, patients with diabetes, patients with higher hsCRP levels. In these cases, the bempedoic acid scores a point over statins. So what are the FDA and EU approved indications? So bempedoic acid is indicated as an adjunct to diet and maximally tolerated statin therapy for the treatment of adults with heterozygous familial hypercholesterolemia or established atherosclerotic cardiovascular disease who require additional lowering of LDLC. The dosage is administered 180 milligram orally once daily with or without food. The same thing is there with the European Union guidelines also. So if you're comparing ezetimibe versus bempedoic acid, ezetimibe LDLC reduction alone 15 to 20%. If you're adding with statin 5 to 35%, bempedoic acid LDLC reduction 15 to 25%. With no statin, it is 25%. And fixed dose combination or drug combination of bempedoic acid plus ezetimibe. So you can see ezetimibe alone 23.2%, bempedoic acid 17.2%. There's a significant 36.2% of LDLC reduction with the bempedoic acid ezetimibe combination. And recently concluded European atherosclerosis meeting, there is a real world efficacy of bempedoic acid in statin intolerant patients. There is 65% of the patients, 67% of the patients tolerated the drug, and there is significant decrease in LDLC, 32.3%. The comparison of tolerability report in clear serenity and clear tranquility with our real world data. Okay. So there is significant tolerance of the drug in the real world population shown with the Belfast study. And we will go to the side effects or adverse reactions of this molecule, bempedoic acid. You can see, I have already told in the initial slide that because of the competitive inhibition of organic anion transporter 2, there is hyperuricemia is there, 1.7% of the patients compared to 0.6%. And gout is there with 1.4%. And there is mild elevations of liver enzyme that is not significant. And anemia is there in 2.5%. Tendon rupture, that's a dreaded complication that is seen in 0.2% on high intensity statin. And there is nothing, new onset or worsening diabetes mellitus is not seen with the bempedoic acid. You can see 4% versus in the placebo, it is 5.6%. So the tendon rupture issue, that is one of the dreaded side effects, but you can see the tendon rupture or injury is seen only in 0.5% of the patients treated with bempedoic acid and no patients receiving placebo. All of the tendon ruptures or injuries occurred in patients taking moderate or high dose statins. And you can see that the risk factors for tendon rupture include statin use, fluoroquinolone or systemic corticosteroid use, diabetes, gout, rheumatoid arthritis, renal failure, patients who are aged older than 60 years, and being male and history of tendon disorders. So patients should be told to rest at the first sign of tendinitis or tendon rupture. Symptoms may include any pain or swelling in the arm, shoulder, back or ankle. Bempedoic acid should be discontinued if tendon ruptures occurs. That is only in very, very small percentage of the patients, that is statin treated patients. But you should keep in mind that if there is any pain in the ankle region or shoulder region on treatment, you have to look for the tendinitis and discontinue the treatment. And rare adverse events, reports of benign prostatic hyperplasia, prostate enlargement, and atrial fibrillation is very rare in the phase 3 studies. Routine monitoring for BPH or prostate enlargement and atrial fibrillation should be part of standard practice for patients with hypercholesterolemia who are receiving lipid-lowering therapy, especially among older patients. Lab monitoring, you can see that small increases in blood urea nitrogen is there, creatinine level is there, with the initial first 4 weeks of treatment, but they are stable and reversible when the patient discontinued treatment. Mild reduction, I have already told you, mild reduction in hemoglobin levels in 5% of the patient, which was apparent within the first 4 weeks of treatment, was stable over time and was reversible on discontinuation of bempedoic acid. And new onset of diabetes, statin versus bempedoic acid. Overall case of new or worsening diabetes is not at all seen with bempedoic acid compared to statin. So the management of patients receiving bempedoic acid, you have to see in renal impairment of patients, there is no concerns, no dosage adjustment is necessary, but not studied in end-stage renal disease. No dosage adjustment is necessary in hepatic impairment patients, but not studied in patients with severe hepatic impairment class C. And monitor all patients, assess uric acid when clinically indicated. Whenever the patient complains of ankle pain or something, you have to look for uric acid. And prior history of gout, increased vigilance for hyperuricemia and gout. In prior history of gout patients, there is 11% increase in gout or hyperuricemia. Patients more than 60 years of age taking corticosteroids or fluoroquinones with renal failure and history of tendon rupture, warn of potential for tendon rupture and advise patients to rest at first sign of tendinitis or tendon rupture. And discontinue if tendon rupture occurs in patients more than 60 years taking corticosteroids or fluoroquinone and history of tendon rupture. Discontinue if tendon rupture occurs. Consider discontinue if joint pain, swelling, or joint inflammation occurs in any patient. And pregnant and breastfeeding patient, there is no data. And before summing up the talk, there's a good news. This is a recently published paper in the ESC Preventive Cardiology 2022 conference. Bempedoic acid and PCSK9 eligibility in contemporary population with atherosclerotic cardiovascular disease. You can see that when you are adding ezetimibe along with the addition of statin, ezetimibe, bempedoic acid combination, around 65 to 70% of PCSK9 eligibility is over. So if the patient, you can see that the proportion of eligible patients of PCSK9 is 100%. If you are adding on high intensity statin or moderate intensity statin on top of ezetimibe and bempedoic acid, the number of patients who requires PCSK9 will be down from the 100% down to less than 20%. So this can be termed as a poor man's Evlucumab or poor man's PCSK9 inhibitor. So this is a significant advantage with the existing new non-statin treatment called Bempedoic acid. So if your patient has got significant atherosclerotic burden or very high risk patient, you can add on moderate intensity or high intensity statin. On top of it, you have to add as a second drug ezetimibe, and on top of it, if you are adding Bempedoic acid, there is significant decrease around to the tune of 65 to 70% decrease in LDLC. That will compare with the reduction of statin plus PCSK9 combination, and that will have a significant impact on the atherosclerotic events and major adverse cardiocerebral events. So thank you all for with this. I am summing up my talk. Thank you all. Over to Samir.
Yeah, thank you, Dr. Krishnakumar. I think that was an excellent presentation, very lucid presentation, and a very good overview of the entire dyslipidemia, current in practice, and what we have new in store. I'm really happy to share that we have a lot of questions. Understandably, we'll have a lot of questions because it's a new molecule. So if you permit me, can I just take up the question and address it to you, Dr. Krishnakumar?
Yeah, go on, Samir. Thank you.
Yeah, thanks. So the first question, as is always a favorite question of amongst all clinicians, is how low would be very low as far as LDL levels are concerned?
See, there are, it requires a little, means 2 or 3 sentences, I will sum it up. You see, the LDLC, the cholesterol, LDLC, in the pathogens, everything is described or by Goldstein and the LDLC discoverers, so Goldstein and Jerome. So those researchers have told that the physiologic level of LDLC that is required for the proper functioning of human beings is around 20 to 35. And the newborn, the LDLC is around less than 35. And the hunter-gatherer populations or very healthy population, they are who are not exposed to Western urbanized diet and dietary habits and living, they are also having less than 50 milligram per deciliter of LDLC. So in the Evlucumab era or the PCSK9 era, the LDLC was down to less than 20 or less than 10 milligram per deciliter in a significant number of patients. So if you are saying how low is very low, based on the current events, you can say up to 25 to 30 is, you can go for 25 to 30 or 20 up to 20. See, the Lipid Association of India now recommends the extreme category patients less than 30. And the physiologic normal in the newborn is less than 35, less than 30. And the hunter-gatherer population, the recent non-statin trials have down up to less than 10 with significant, very good safety record. So how low is very low, that is yet to be seen. But right now, you can say 20 to 30 is 20 to 25, 25 to 30 is low. It's a significant safety profile.
Sure. Thank you. There's a question from Dr. Shetty. In the Indian scenario, how frequently do you come across statin intolerance?
Statin intolerance, I think it's a much hyped up thing, because most of the time, statin intolerant patients, what with the physician or the cardiologist who are regularly seeing the patients, whenever the patients are saying, I'm having aches and pains on taking this drugs, it is because of the statin. They will assume because of the internet and social media influences, they will say, and most of the patients are afraid of the word statin because everywhere on the social media or the print media, statins are causing significant side effects. So they will attribute statins are causing this muscle aches or symptoms. But the muscle aches and symptoms, pains are mostly due to underlying hypothyroidism, underlying vitamin D deficiency, or the other fluoroquinolones or other drugs which are interacting with the statins. So you have to treat the hypothyroidism, you have to treat the vitamin D deficiency, then you can see that the statin intolerance will be down to less than 10% or 7 to 10% of the patients. Even in statin intolerant patients, you can go for statin therapy as a weekly, twice micro dose of statins. Even with that regimen, very low dosage of statin, 16 to 26% of the LDLC reduction is there. So the answer to the question by Dr. Shetty is statin intolerance is not common, And in India, there's no proper study of statin interferon has been conducted as far as I know. So it would be less than 7 to 10% of the patients.
Dr. Kumar has a question. Can bempedoic acid be given with PCSK9 inhibitors, and what would be the expected results?
Yeah, because I'm having a significant number of familial hypercholesterolemia patients that are heterozygous. And high atherosclerotic patient also, I think till now I have prescribed around 20 to 25 bempedoic acid prescriptions, and around 5 to 6 patients I have given along with the high intensity statin with ezetimibe plus PCSK9 inhibitor. On top of that, I am giving this thing, bempedoic acid. So if you are calculating the amount, but PCSK9 I am giving only 2 or 3 shots because of the very prohibitively costly therapy. So if you are adding up the percentage LDLc reduction, high intensity statin plus ezetimibe plus PCSK9 will come up to 85% of the LDLc reduction. And if you are adding bempedoic acid, I think significant amount of LDLc is gone. Around 100% of LDLc is gone. But mind you that the recently concluded European Atherosclerosis Society just now, I think 2 weeks back, Borsche, not God. That is he is a very famous scientist, professor of cardiology from Denmark, Copenhagen. He has said that apart from LDLc, there's a new player in the atherosclerosis. Any molecule that is less than 70 nanometers, that is remnant cholesterol, that is also for residual risk. So what I'm trying to convey is that 100% of the LDLc is gone with the current regimen of bempedoic acid plus ezetimibe plus high intensity statin plus PCSK9. But PCSK9 is very costly in our country.
Dr. Prasad from Pondicherry has a question. Can bempedoic acid be given with ezetimibe without initiating statins?
First of all, let me make it clear that, first of all, the first line treatment in any situation is statin. Initiating therapy in a patient with bempedoic acid with ezetimibe is not at all good, because if the patient has a clinically or significantly proven case of statin intolerance, you can start with bempedoic acid and ezetimibe. But starting upfront with ezetimibe and bempedoic acid, that is not a good idea as far as LDLc reduction is concerned. You have to start the patient on optimal statin therapy, maximally tolerated statin therapy, and on top of that, you can add as a second drug ezetimibe, then only a third drug bempedoic acid. But because there is a significant number of very high risk patients in our clinical patients, you have to have an addition of a third drug like bempedoic acid. So the answer to the question is bempedoic acid plus ezetimibe combination starting upfront is not a nicer idea. You can start, but it's not a good idea.
Dr. Mehta from Mumbai has a question. If we have to start bempedoic acid in hyperuricemia patients, how frequently should we monitor the uric acid levels?
Because one of the problem with the bempedoic acid, because all of my patients as a baseline, I will start uric acid levels, and if the uric acid is increased, I won't start the bempedoic acid as such. And I will consider other risk factors also. Male patient more than 60 years, if the patient is asthmatic on take or rheumatoid arthritis taking steroids, or if the patient is having infection taking fluoroquinolones, I won't start the patient on hyperuricemic patient on bempedoic acid. But hyperuricemia means if you need significant atherosclerotic plaque burden reduction, you have to treat the uricemia first. Hyperuricemia patients mostly having increased hypercholesterolemia, increased atrial fibrillation, increased hypertension incidences and all. So it is not a good idea to start these patients on hyperuricemia patient on bempedoic acid, but you have to treat the hyperuricemia and start the patient on bempedoic acid. But mind you, you have to observe the patient for any pain in the biceps, means ankle region, shoulder region, rotator cuff region, biceps region, for possible or warning signs of any tendinitis or tendon rupture. It's not a good idea to start the patient on hyperuricemia. So in those patients, you can start statin plus ezetimibe initially. If you are not achieving any significant decrease in LDLc, you have to treat the hyperuricemia with the allopurinol or the febuxostat and you have to control those things, then you can initiate bempedoic acid. But there are no trial data or scientific evidence for this statement right now.
Dr. Ghosh from Kolkata has an interesting question. Bempedoic acid is used over and above statins. Statins have shown to increase the new onset diabetes. As compared to placebo, the new onset diabetes was lesser with bempedoic acid. So would a statin and a bempedoic control with statin would help in mitigating the risk of new
because bempedoic acid plus statin combination, the statin side effect of new onset diabetes is still there with the combination. It is not being mitigated. That's what I know from the trials.
Sure. How would you envisage the use of bempedoic acid in primary prevention patients in the Indian scenario?
As a primary prevention, we will go for statin first, then statin in higher dosages. Because if the patient is not achieved with the goals, we will go for ezetimibe. But giving bempedoic acid and primary prevention, especially if the patient is on significant, if the patient is familiar, not on homozygous or heterozygous significant cholesterol elevation, heterozygous familial hypercholesterolemia, as a primary prevention method, I won't see any brighter prospect for bempedoic acid in this set of population. But in a patient with a history of premature coronary artery disease with high cholesterol and all, it is better to go for LDLC, significant LDLC reduction. Because the newer concept of atherogenesis or the LDLC reduction is start early and continue low as possible. So duration of duration of the LDLC treatment, as well as you have to start it early also for the continuous reduction of LDLC. We will be calling it, as in the case of smoking, we will be saying it as PAC years. So in the case of cholesterol, we will be saying that LDLC years, LDL cholesterol years. So if your LDLC is controlled less than 100 milligram or less than 70 milligram from the age of 25 or 35, so you have a significant advantage in the reduction of atheroma. So that sort of concept is coming from the West. So that is possible with the familial hypercholesterolemia patients with the significant high cholesterol. But otherwise, for the primary prevention, I am not seeing a brighter prospect.
Okay. Dr. A.R. Padmanabhan from Erode has a question, rather 2 or 3 questions. How long should it be given? What are the side effects, and is it universally accepted by cardiologists?
Yeah, that's a very nice question, because this molecule has been launched in the US and Europe 2020 February and 2020 March or May in Europe. And since then it is 2 years down, only 2-year data is there, and the significant cardiovascular outcome trial, that is whether it is safe, whether it is having good cardiovascular risk reduction, that is cardio CVOT trial, is not yet out. The results will be out only 2023 last quarter. That is clear outcomes trial. Till then, you won't be able to tell that this is having a good cardiovascular benefit in terms of trial-based or evidence-based data. But it is efficacious in reducing LDLC, it is efficacious in reducing hsCRP, and it is safe, fairly safe. So for the acceptance of cardiologists as a new drug, see, right now the goal of LDLC in very high risk patient, if you are patient, ACS patient or acute coronary syndrome heart attack patient, your LDLC has to be down to 50 milligram per deciliter. And if you experience, is there any target organ damage or polyvascular, PAD is another tertiary vascular problem is there, the LDLC reduction has to be down to 30 milligram. So you need treatment apart from statin, high intensity statin, you need ezetimibe, and you need, on top of that, you need another non-statin drug, either PCSK9 inhibitor or bempedoic acid. PCSK9 inhibitor is very costly. So you can take it as a poor man's Repatha or poor man's Evlucumab. So, but you have to monitor the patients for hyperuricemia. You have to monitor the patient for gout. You have to monitor the patients of symptoms of muscle pain or all those things, like any other drug. So it is fairly a safe thing. Real world data is out in the recently concluded European atherosclerosis meeting. Around 65 to 70% of the statin intolerance patient is tolerating the drug with significant 32% decrease in LDLC. So drug is not a bad thing. It's a very good combination, a very good drug with a fairly good safety profile. So the cardiologist will accept, but only when the CVOT outcome trial is out, the people, the majority of the cardiologists will accept this as a safe drug, means effective drug.
There's a question from Dr. Singh from Patna that bempedoic acid is also known to improve the hsCRP as seen in all the 4 phase 3 trials. So keeping this point in mind that hsCRP is an important CV risk factor, post a maximally tolerated dose of statin, in view of this finding, what would be the choice between bempedoic acid and ezetimibe?
See, statins will decrease hsCRP in Jupiter trial and all. So statins also decreases hsCRP. And ezetimibe, there's a fairly small amount of decrease is there with enhance and other CESAR trial is there. That is, decrease is there. But significant decrease in hsCRP is there with bempedoic acid to the tune of around 25% or 26%, 26 to 30% in all these 4 trials. So that has got an advantage over with ezetimibe. But even then, whatever said and done, the second drug to be added on top of statin, high intensity statin, should be ezetimibe, and only the third thing is bempedoic acid. But mind you, most of our patients, especially secondary prevention patients, all the CAD patients, you need bempedoic acid for the proper control of the LDLCs. You have to go to as low as possible by 50 milligram or 30 milligram of LDLC. You need a third drug on top of your high intensity statin plus ezetimibe combination. Addition of hsCRP lowering is a very good thing that needs additional trial data for the CVAT outcomes data.
So I think we are almost done with all the questions. Few of the questions were repeated, so I won't repeat them. So also I have received few feedbacks that the presentation was very lucid and the questions are being addressed well. So my regards to you, Dr. Krishnakumar. So before we wind up, can we have the final take-home messages from today's webinar from your end?
Yeah. See, the first, the topic of our discussion is the role of bempedoic acid in the management of LDLC. See, in India, there is a significant amount of dyslipidemic patients are there. Significant number of CAD patients are there. Hypertensive patients are there. Diabetic patients are there. The major underlying mechanism for the atherogenesis is dyslipidemia in these patients. And the major driver of atherogenesis is LDLC. And most of our patients, even not from India, the highly educated, highly advanced countries like Europe and all, there is significant underutilization of statin treatment is there. So first and foremost thing is you have to treat your patient with not with low dose statin, not with moderate intensity statin. You have to treat the patient with a maximally tolerated statin. You go for rosuvastatin 40 milligram, or you go for atorvastatin 80 milligram. If the patient is not controlled, if the LDLC is not controlled, controlled means right now the level of LDLC is down to 50 milligram or 40 milligram in the case of recurrent ACS. So if the patient is not controlled, you have to have an additional non-statin drug like ezetimibe, and on top of that you need bempedoic acid or PCSK9. And since the PCSK9 is not affordable by the majority of not the majority, 99.99% of the patients over in India, you need a third drug that significantly decreases the LDLC reduction with statin ezetimibe combination to the tune of 65 to 70% of LDLC reduction. That will pave the way for regression of the atherosclerosis. So the role of bempedoic acid in India is right now with a very high untapped potential of undertreatment of dyslipidemia in our patients is very high. The role and the place of bempedoic acid in the management of dyslipidemia in our Indian patients is very high. So you have to have a proper treatment of dyslipidemia in our patients.
Thank you, Dr. Krishnakumar Pillai. I think that was a really good summation of what we discussed today. And as I already mentioned, there are a lot of compliments from the audience with respect to a very lucid presentation and a very good, lucid addressal of all the queries from your end. So on behalf of the audience, I thank you very much for making it today evening, that too in the midst of your ill health, as I understood that you were running sore throat and fever. So again, a note of appreciation from our end to still have continued the meeting and given a great oration. And thank you very much for all the attending audience again to have spent your family time at this time for this academic feast. So we know all that now there are fresh crops of COVID cases being reported in few parts of the country. So let us again stay safe, stay healthy, and may God bless each one of us. Thank you very much.
Okay, thank you, Samir. Thank you all.
Thank you. Thank you.